Hello, I'm Jeff Spence from the Jefferson Alumni Office, and it is my pleasure to welcome you to this evening's talk. Tonight, we will explore the physical and cognitive clues that can help you identify concussion and discuss the precautions you can take to protect yourself and the athletes in your life. Our speaker is Dr. Robert Franks, an associate professor at Jefferson and director of the Rothman Sports Concussion Institute. Dr. Franks is a board-certified family practice physician with a certificate of added qualification in sports medicine at Rothman. He specializes in medical orthopedics, sports medicine, and is one of the nation's leaders in sports-related concussion management. When Dr. Franks begins our presentation, please share any questions you have by using the Q&A button at the bottom of your screen. We will address questions at the end of the talk, and we'll do our best to include as many as time allows. And now, it is my pleasure to welcome Dr. Franks to begin our talk.
Well, thank you, Jeff. Good evening, everybody. And I appreciate your coming on to the computer this evening. I know there's a lot going on out in the world and there's a lot of uncertainty. So for me, who's kind of in the coronavirus world every day, it's nice to kind of get back after a month of kind of dealing with masks and hand washing and so on and so forth, back to some sports medicine. So thank you for attending this evening. So my objective tonight is to convince you that with concussion that rest is no longer best. We're going to talk about some of the history clues that we see in terms of diagnosing a concussed athlete. We're going to talk about some of the physical examination things that I look for and some of the new treatment modalities to return to learn and return to play. So if you take one point home from this lecture, the thing I want you to take home is rest is no longer best. The new mantra is expose and recover. And I think it's very important that we talk about this because this year is going to see another renaissance in concussion. Every 4 years, their concussion in sports group, which sends representatives from the majority of the countries in the United States that have contact collision sports, as well as an interest in sport, sends representatives to Europe where there's a meeting. And because concussion is evolving, we kind of look at what do we know, where do we need to go, what changes do we need to make. And this conference, provided everything works out with COVID-19, was and is still supposed to be in Paris this fall. So there's going to be a lot of changes that take place in Paris. And I was on the writing group that is going to send the information for the United States delegation to Paris. So we're hopefully giving you, the most up-to-date information we can give you on concussion. There's a lot of slides, but because this is a video chat and you have access to the slides and not me, I am basically going to go through and try to give you what you need from the talk. Jeff is telling me that you can't see the slides, so I'm going to try and see if I can go ahead and change that for you. Jeff, how are we doing? Can you see it now?
Not just yet, Rob. If you share screen at the bottom, and then you should be able to select your PowerPoint.
Share screen at the bottom.
Mm-hmm.
There we go.
Success.
How are we doing? Perfect. Okay. So you guys really didn't miss anything. So we're going to, just my fancy slide that we went ahead and we put there. Okay. So really we're on the third slide. So as I was saying, every 4 years, we basically do a conference where the last one was held in Berlin, 2016. And I think the most important thing that came out of Berlin was the idea that we're no longer putting athletes at rest, putting them in a dark room, not having them do anything as far as activity is concerned. And what we're really trying to do is bring them up to a point where they start to become symptomatic as we put them into recovery. And then we bring them back just a little bit so that we can keep moving forward in terms of getting them through a recovery process. There's no one protocol that's used to do this. And unfortunately, there's no one consensus statement or one paper that tells us how to do this. So it's really a combination of the practice experience of the individual physician and exactly what the athlete is demonstrating to us that we need to kind of react to and observe to get them where we need them to be in terms of return to play and return to school. We've actually changed the terminology. The terminology now is sports-related concussion. And any concussion has to be looked at as, has the concussion itself gotten better? And that means the concussion itself cannot be influenced by drug use, alcohol use, and most importantly, other medical comorbidities. There is a big psychological component to concussion, and there's a lot of coexisting medical conditions, such as migraine, that can influence concussion. So that when we're making decisions, we have to be sure we're dealing specifically with the concussion itself and not reacting to, post-concussive anxiety, post-concussive depression, or if someone is migrainous, that we're seeing the migraine take over and the concussion headache has abated. There's two tests that are used most times when we start diagnosing concussion. So if you have kids that are playing sports right now, the SCAT5 and the child SCAT5 are the tests that we basically use on the sideline to initially diagnose a concussion. We basically put them through a series of examinations on the sidelines, and you'll watch us have them do balance examinations, eye examinations, memory examinations, and this is basically going to tell us, do they or don't they, do we believe on the sideline, have a concussion, which gets them into the system. It's probably the best looked at and best examined test from a research perspective, and we divide it up on both pediatric and adult concussion testing right there on the sideline. I think people ask me all the time, how do I know someone's really going to have a hard time? And we've looked at loss of consciousness, we've looked at amnesia, and we seem to feel that based on Berlin 2016, and this is probably not going to change, is really what is the condition of the patient within the first 24 to 48 hours. If they have a whole lot of symptoms on a symptom checklist of concussion, we pretty much realize that they're going to have a harder time with recovery. If they're pretty minor when we first initially see them on the sideline, a lot of times it's a much easier recovery. So what are the key historical points? You guys can read on your computer, and I put some of them in yellow because I think these are the things that really need to stick out. Our emerging female predominance. It has been shown in the literature that females take longer to recover from concussion, and their symptoms are often and cumulatively much worse than the male equivalents. And people always ask, what is the reason for that? And I think when we get right down to it, we're going to find that it's going to be just like the ACL. It's probably going to be the shape of the cranium of the female is different than the male. Neck musculature is different between men and women. The hormonal cycle is going to play a role with women as opposed to men. And I think once that research is completed, we're going to see it's multifactorial, meaning there's many things that make it harder for women than it is for men in terms of recovery. Any athlete that has a comorbid headache history or history of mood or mental health disorder may need special consideration. We see a lot of athletes that, in the new literature telling us that within 7 to 10 days, a lot of our high school or collegiate athletes are already having some degree of anxiety or depression. It's not true major depression or true anxiety disorder, but it is enough that the symptomatology of the issue with anxiety or depression is driving the concussion. A lot of times patients who already have an issue with motion sickness tend to have a harder time recovering. And that means that their eyes, brain, and body are already not working correctly. And these are going to be the kids who say, as soon as we get into a car to go on a long car ride for vacation, I get car sickness. And a lot of times we don't ask about that. We often ask them what kind of headaches they have. Are they moody or irritable? And a lot of my parents say to me, they're a teenager. How can I tell if they're moody or irritable? They're miserable all the time anyway. So a lot of times we try to get in touch with the athletic trainer at the school or one of the medical folks at the school, i.e. school nurse, who could tell us, is this the disposition of your athlete, or is your athlete really showing that they're having more of a mood issue? I always talk about the word foggy whenever I lecture. And universally, because I've lectured not only regionally, I've lectured across the United States, and I've done at least 5 European lectures. And foggy is always defined as the same thing. People just don't feel right, quote unquote. And I think the best definition I ever heard was from one of my NFL players who said, it's like watching HD TV. And then somebody goes up, pulls out the HDMI cable, and the picture is not as crisp. The sound is not as crisp, but you're all seeing the same picture. And whenever any adolescent can describe that to me, I get a little bit more on my toes because I realize it's going to be a little bit more of a challenge to get them better. We also want to know about wearing glasses or contacts, because if we don't know they're wearing them, a lot of times we see issues with vision. If we don't know someone already has glasses or contact, the prescription, if we're trying to help that concussion along, can certainly be affected because we don't know originally what their prescription was. So we have to ask about that. The University of Pittsburgh Medical Center, I think, did the best job in terms of putting together a categories system to define concussion. I tell the residents and the medical students that a concussion is like a war. If you don't have a game plan to try and win the war, you can't win the war. So UPMC has divided these up into vestibular, which is the eyes, brain, and body not working together, having issues with balance coordination. Ocular, which is the inability to lock in on target, the inability that when I change the distance of an object, the eyes can't adjust. Cervicogenic means they're having neck pain, all right? And a lot of times we focus so much on the concussion, or let's say it's an orthopedic issue on top of the concussion issue. A patient has a broken nose or a broken jaw. We don't ask about neck pain. Anxiety, mood, we already talked about. Depression, anxiety. Cognitive fatigue, they just tucker out by the end of the day, or they can't concentrate appropriately. And post-traumatic migraine, meaning a migraine headache that comes as the result of a concussion. Some of the things that, cervicogenic is pretty easy. That's neck pain. We already talked about, cognitive symptoms, cognitive attention. They can't concentrate. They feel foggy. Emotionality, we just talked about. Sleep can be any type of fatigue or sleep. Some people can't fall asleep. Some people can't stay asleep. Some people are sleeping less than usual. Some people are sleeping more than usual. It really runs the gamut. And vestibular, ability of eyes, brain, and body not working together. Post-traumatic migraine, I put in yellow. And I think the reason I do that is because everybody who gets a concussion headache, people think it's a migraine. Those of you who have migraine histories out in the audience know that a headache is a headache. A migraine is a headache that has nausea and either ability to be sensitive to light or sensitive to noise. And that's especially hard in the adolescent population because kids end up having their migraines diagnosed when they're teenagers. So a lot of times the concussion becomes a trigger for the migraines. So you have to realize not every headache is going to be a migraine. And a lot of times kids who are already migraines can say to you, this is not like my migraine. It's completely different. And kids are very good with giving you that description if you help them, you help their parents understand this is a migraine, this is a plain headache, and what are the difference between the two. So if you come into the office, what kind of physical exam are you going to do? We're going to do the same thing, and I'm going to go through just kind of the nomenclature that's up there. Speech, looking at your walk, what are your reflexes when we hit you with the hammer? What's your muscle strength, both in your upper and lower extremities? What's your sensation? Can you feel me or not in your upper and lower extremities and your cranial nerves? How is your facial musculature and the things that look at hearing and eyes? Do they react the way I need them to react when you're in the office? Some of the things I put up there for the clinicians who are out in the audience, and these are some of the testings which are really not important. What you really need to know as the layperson is I'm looking at not only how the central nervous system is, brain and spinal cord, but also how the limbs are working, and is this all working together in the nervous system. You'll see VOMS, which is called the vestibular ocular motor screen, in yellow. And it's in yellow because it's probably the biggest advance we've had in concussion management in terms of a physical exam. And it is probably what you're going to see a lot if they don't get the 10 up in time when you're looking at an NFL game, because it examines the central nervous system, how the eyes and how the balance system are working once we test it. It's going to look at the ability to lock in on target, which is called convergence. That's with your eyes. Changing the visual distance of the object and having the eyes adjust. That's called accommodation. And if you think about it, that's all the things that our athletes need. I take care of the Phillies, and one of the things that separates me from the Phillies, besides the money, is the idea that when I lock in on target for a baseball, it's work for me. When they lock in on target for a baseball, it's second nature to them. The other things I look at in the vestibular motor screen is the ability to move from target to target with the eyes, the ability of the eyes to follow a target, and then finally, the eyes, the brain, and the body working together in what's called the vestibular ocular reflex or vestibular motion sensitivity, which basically, in plain non-medical terms, is does the brain realize an object is stationary when you move the head? And does the brain realize that if you move an object at the same time as you move the brain realizes you're both working together? I.e., if you're watching a tennis match and you follow the ball from one side to the other, the brain knows that ball is moving and it's following the ball moving if you're sitting at center court. The same thing goes for the ability to cancel that out, which is called the vestibular ocular reflex. And that's looking at an object and moving the head, and the head realizes. So if we're looking at the goalpost and we're moving the head to kind of see what the distance is for the kicker to kick, the brain realizes that goalpost isn't moving. It's the brain that's moving to judge the distance. Balance as a score, or our scoring system is a way that we look at balance. We do 3 different positions: feet together, up on one foot, and essentially one foot on top of the other, on front of the other. And we see how many mistakes you make with balance. And that gives us an idea, what is your balance like? I put sway balance into yellow with this is because we're moving away from that. And the reason we're moving away from best testing is because that's done subjectively. My criticism of someone's balance may be different than one of my partners in the Rothman Institute. So sway balance, and I call that out because it's the most common one used, is basically taking a gyroscope in your iPad, clutching it to your chest, and it's going to tell us what your balance is like. So we have the ability now to actually do testing using technology as far as balance is concerned. So one of the things we're hoping to get from this next European conference is, what kind of classification do we have? Because quite honestly, we really, after 4 to 5 conferences, do not have a great classification. It's basically, there's 90% of the patients that are going to get better in 7 to 10 days, and then there's everybody else. And we've actually gotten rid of the term post-concussion syndrome. So a lot of the stuff we've seen and the things that you watch on TV, 20/20, 60 Minutes, Real Sports, we now call persistent post-concussive symptoms. And these are symptoms that last greater than 14 days in adults or 4 weeks in kids. And these are the type of patients that I mostly see. The concussion is probably over, but for whatever reason, they have these symptoms that are kind of hanging on. You know, people ask me, when do we image? Well, we've really gotten away from imaging. So a CT scan is a big dose of radiation. So the European conferences recognize that neuroimaging is usually not going to help us unless we think someone has a skull fracture, they've had a seizure, they have some kind of brain bleed, or their symptoms just aren't getting any better. And that's when we're really going to image. And we're really moving to MRI. MRI with DTI is a way of looking at the axons, which are the nerves of the brain, and seeing how that nerve impulse is kind of conducted, kind of like Comcast or Xfinity or whomever you use, Verizon, gets the signal from the pole into your house. We want to know what's happening along those wires, which are exactly what the neurons are in the brain. Are those impulses getting from the neurons connected to the body, just like the nerve impulse is coming appropriately from the pole outside into that TV? And we think the functional MRI, which is a way of doing an MRI while someone's doing a task, so we can look at the brain, is the wave of the future. And that's something that as you kind of follow sports and watch TV, you're going to see more and more of this done as the technology gets cheaper and becomes more widely available. Because right now we're just doing this in study to see how does the brain react when we give it a task to do. If we ask it to play with a Rubik's Cube, are the appropriate parts of the brain firing or is it not firing? And I guess using a Rubik's Cube, I just dated myself, but I'm hoping that most of the people here on this talk are at least in my age group and know what I'm talking about with a Rubik's Cube. Neuropsychological testing is extremely important, and it's basically looking at how is the brain functioning. It's looking at brain processing, planning, memory, and the ability to switch from one set of thinking to another set of thinking. And ideally, if you watch the NFL and you hear about NFL testing, we try to do a test before the season, which is called a baseline test, and it basically tells us what is your normal cognitive functioning, the way the brain is working. And then we do it after you've been concussed, and we see what the difference is. And it's really important in our teenagers because we need to make return to learn decisions. And return to learn is basically how deviated can they or can't they be? And I need to make decisions about going back to school based on how deviated they are. And then finally, we also use that data to make some decisions about returning to play. So when we do any kind of assessment, and that's usually if you guys have kids in school, when your kids take the computer test, regardless of which test it is, we're always looking at verbal memory. That's the ability to process verbal information, voice information, words information, visual memory, some kind of visual object. Visual motor speed composites, the ability to process visual information quickly and accurately, i.e. if I'm watching a play in football, I'm seeing the play, but I'm also processing what type of play that is. It's a pass play, boom, my brain recognizes that. And reaction time is how quickly the brain is reacting. I think one of the stats that is most interesting for me is that even though we're doing this testing, I'm in New Jersey, and we are very fortunate that we have greater than 93% athletic training coverage, which is the certified medical provider in the school. We have greater than 93% coverage, but only 55% of our athletic trainers looking at our baseline testing. And that testing can tell you a lot, because if you have on your baseline problems in one of those domains, then you know probably with a post-test that there is going to be some kind of problem that we're going to have to address as they're going through the concussion process. So what's my job? So there's a lot of R's, and you're probably thinking, where did this guy get all these R's? So the results of the last Berlin conference, where these are all the things as the provider we need to do. We need to recognize if someone has a concussion, remove them from play, reevaluate them. Is their sideline evaluation different from what happens in the office? I tell people I'm now the third man in. Most kids are seen on Friday night, then by their athletic trainer on Saturday in some kind of injury clinic, then in urgent care, then they finally get to me. Resting them initially, rehabilitation. What kind of game plan am I going to put together to get them better? Referral. Am I going to need, I tell people concussion is treated as a team. I may be the quarterback, but I have a vestibular therapist who's a therapist who works with balance. I have a psychologist if someone is depressed or anxious. I have a neurooptometrist who works with eye movement if necessary. So do I need to refer to one of these specialists? And my team has about 10 different people on it. Recovery. What's the recovery like? Return to sport. When can I let them go back? Reconsider if there's a problem when we put them back. Any kind of residual effects. Is there, when they go back, are they having some kind of problem that we have overlooked, or they somehow got through return to play and they're having a problem? And what are we doing now in the future to try and decrease concussions? My job is also to prevent second impact syndrome. That's all the horrible stories that we hear probably every other year about someone who has not recovered from their initial concussion, have a second one, and usually the effects are devastating. The brain swells, and it's usually, if not death, significant mental or physical impairment. Prevent the cumulative effects of concussion, meaning that the effects get worse with the increasing numbers of concussion, and finally to alleviate symptoms. My treatment goals must take into consideration that migraine, anxiety, post-traumatic stress, problems with attention and sleep may influence the driving force behind the concussion, but me as the clinician need to be smart enough that I may be treating an anxiety problem on top of a concussion and have to look at them from two different sides. How do you treat the anxiety? How do you treat the concussion? Rest now is only in the first 24 to 48 hours. We take the iPad away, try not to do a lot of heavy duty activity, try to make them just walk, and try to get them as complete and mental and physical rest without stressing them out as possible. And when I use the term stressing out, those of you who have followed concussion know we used to put you in a dark room and play classical music. And what 14-year-old these days are going to tolerate that? We were making them worse instead of making them better. What's my first line treatment? It is usually the same. 3 meals a day with heavy emphasis on protein ingestion, because with carbs, sugar up, sugar down, energy up, energy down, trying to hydrate the brain, sleep 7 to 9 hours, no naps, no electronics in the bedroom, because the blue light keeps people awake, and we try not to have them nap because it messes up their sleep-wake cycle, and try to get them exercising by walking only. These are a lot of words on here, but basically what we do is we divide it up into the symptoms we talked about, and we try and fix it. Vestibular is balance and coordination. Kids become really anxious with this. Imagine being a high school senior going into the same hallways that you've gone in the last 4 years, and you can't figure out how they get around the door that's opening between periods because you can't judge, even though you've walked around that same door because it's named near your locker for the last 4 years, you can't judge how to get around it, and that really stresses people out. And oftentimes we see patients having problems with balance and coordination more with movement, that's what dynamic means, than static, just keeping them in place. A lot of them, if you test their balance without moving, they do fine. As soon as you start them moving, changing their level, changing their position, they have a significant amount of symptoms. And the big treatment for this is going to be something called vestibular therapy, which is basically therapy for balance and coordination. We want to try and help them with anxiety, because to get them to understand that this is normal and try and mitigate this anxiety. We try to exert them right away so they get their confidence back, try and get them exercising. In terms of medicines, Clonopin seems to be the best, but we also use those other medicine choices, SSRIs, tricyclics, are really anxiety medications. I have to be honest, I can't remember the last time I prescribed a medication. When we get the new guidelines for this year, medicines are really going to be underemphasized. We've gotten much better at our therapies, and I think they're much more critical. Anxiety, mood, we see that as quickly as 10 to 14 days since they've been concussed. And this type of patient are going to be the type of patient where if you ask them a symptom, they have that symptom. If you say to them, do you have this symptom? You have it. Do you have this? Yes, I have it. Patients will have parents come in with binders detailing every movement and every thought that the patient has, which feeds into the patient's own anxiety, which stresses them out. And sleep is often a problem with these patients. So what do we normally do with them? How do we treat them? We treat them with cognitive behavioral therapy, which is basically we isolate that thing that's got them stressed out. We kind of repurpose that behavior to try and get them to think of it in a more positive manner, i.e., I'm stressed out because my balance is off, but if I fix my balance, I'm going to become less stressed. We try to exert them, try to get their behaviors under control, and sometimes we do need to use medications for anxiety, but very rarely do we use that. And if we're going to use one, it's usually Zoloft. Ocular is the inability of the eyes to get the information from what the patient is seeing into the brain. These type of kids have a hard time imprinting information. So they understand the story of Great Expectations. They can't get the printed word into their brain. So if you have an audiobook read to them, they get the story, they can keep up with their peers. If you tell them you have to read 2 chapters tonight, they tucker out and they just can't do it. And these type of kids obviously have problems with math and science because they're very visual subjects and they tucker out by the end of the day. How do we treat them? A lot of them have also issues with balance and coordination. So we treat that at the same time as we do vision. And people say, well, what's vision therapy? Vision therapy, believe it or not, is physical therapy for the visual processing part of the brain. We have the eyes working, going from target to target, following a target to retrain the vision part of the brain to start working appropriately. We also exert them, and sometimes they get very stressed. The kids who have the hardest time are your high functioning kids. I'm the AP honors kid who really doesn't have to work that hard to get AP honors. And now that chapter, which would have taken me 20 minutes to read, is now taking me an hour to 20 minutes to read. So we try to support them. We're trying to use other means to get that information into them, audiobooks, people reading to them, so on and so forth. Cognitive fatigue are the kids who tucker out pretty much by the end of the day. We see essentially that these kids can't bring the information forward. Every period that goes by in school, they tend to do worse and worse and worse and worse. So how do we treat them? Well, we treat them, what we try to do, what's called accommodations. Those of you who have kids who have already been through concussion, this is giving them more frequent breaks, trying to change from like a Scantron. Again, I'm probably dating myself, but that's any test where you bubble in and getting them to do like a dictation test where they kind of verbally are telling you what's going on. Because a lot of times these kids understand the material, but you ask them to bubble, they can't really get themselves to the point to follow all those bubbles. They kind of peter out, and then they're just circling it. They're bubbling in anything because they're having such a hard time focusing on A, B, C, D, and E. Cognitive rehabilitation is basically reteaching somebody how to learn or how to use information more efficiently. Medications, we've really gotten away from. Some people need stimulants, but it's extremely, extremely rare. Cervicogenic is getting them into rehab for their neck. Pretty much everything that involves range of motion and strengthening of the neck. And these are all the things that if you've ever had physical therapy that you've been through. You know, muscle relaxers, a TEND unit, which is using electrical impulses to help with pain, osteopathic manipulative medicine, trigger point injections, epidurals. Post-traumatic migraine, as we talked about, is any headache with nausea and visual or light sensitivity. And basically what we do with this is we treat it as we would any migraine. Those of you who have migraines, we know a lot of times we use beta blockers or we use medicines that are in the tricyclic class, which would be like your tricyclic antidepressants, amitriptyline, nortriptyline. Now, one of the things that we were really concerned about with the last conference was we had 2 return scales that we put together: return to school, return to sport, and they both labeled them RTS. So with 26 letters of the alphabet, we really in the United States were wondering, why did we make it RTS, return to school, return to sport? It would have probably been better if we said return to class, return to learning, which a lot of people use that term. So you got to kind of be clear which we're talking about. Is it return to school or return to sports? Right now, we're going to talk about return to school. There's been a lot of proposals, but this is the first one that has been universally accepted as return to school. Initial rest for the first 24 to 48 hours. And people say to me all the time, well, the first thing I did is I took my kid's phone away. Well, quite honestly, we're not doing that anymore. Once we realize they're able to do the cell phone, which is part of their everyday activity, they've already gotten to step 1, texting, reading off the cell phone. We want to get them doing their normal activities. Second is doing school activities, getting some of that homework done, trying to get some reading done that's not pleasure reading. Return to school part-time, because we talked about the idea that a lot of times kids have cognitive issues, so they get worse as the day goes. So sometimes we alternate AM, PM, and try to get them at least some degree of socialization, some degree of classwork during the different parts of the day. And finally, stage 4 is return to school full time, putting them back for a full school day. And I think it's always best to have a game plan with their guidance counselor, with their teachers, with their athletic trainer of what the expectation is. And I think if parents are really proactive with this, it's much easier on the patient. We now have schools in our practice that we know they've got this down. We're not worried about putting kids back into school. And then there's some districts that are so fragmented, we literally have to walk them through the process regardless of how many concussed kids they've had in that district. Return to sport is a little bit more straightforward because it's been around since the early 2000s and hasn't changed. But I will tell you, for those of you who have had concussed kids, and that's probably quite a few of you, the majority of them in any age group that is probably from the late teens on have gone through this, and you watched your own kids go through this. This return to play protocol that was first put together in Vienna in 2001 has not changed. That means it's approaching 20 years old. There's no data behind it. It's what we think is the right thing to do. It has a target on its back for, if not this conference, probably the next one. Coronavirus is probably going to change, time course and how much work is getting done for this. But because there's no science behind it, it's probably going to be one of the things that changes shortly. How is this done? Step 1 is basically we start with pretty much absolute rest. Second thing that we do, because we do it in order, it's done one step at a time, one day at a time, and each step is 24 hours. And if you fail one step, we knock you back to the previous step and we start again. Step 2 is light aerobic exercise. We want to get you up to about 70% of your maximum heart rate. But we don't want to do anything that jeopardizes balance and coordination. So we put you on an exercise bike and we try to get you up to 70% of your maximum heart rate. Step 3 is sport-specific exercise. We try to do things that are specific to your sport, i.e., if I'm basketball, I'm going to dribble. If I'm hockey, I'm going to ice skate. Nothing that can potentially injure the head. You're adding movement in your return to play. The 4th step is non-contact training drills, and that's basically doing exercise coordination, and now we're adding cognition, or the ability to think. If I'm the wide receiver, I know I need to run down the sideline, and then I need to cut in 20 yards and now come across the field. So we're adding thinking into that activity. And finally, it's a full contact practice once we do a final medical clearance. Every professional organization, IOC, USOC, NCAA have adopted this pretty much as gospel, and it has not deviated since 2001. So long story short, the thing that really guides us if we take care of concussion, which is why it is so challenging and takes a while, is that I tell the interns and the students and the residents that we have 3 things that we have to remember. We have to remember that every state now has a concussion law, and most of them are being rewritten because they were written expeditiously and they were written without all of the information to put together a good concussion program. So we have to think about, when we put together a game plan, not just returning someone from the medical aspect, but also returning them legally. Do we meet all of the guidelines within that particular state that we're meeting what needs to be done for the concussion state law? And has your state actually changed the law? Because New Jersey has about 3 bills before the legislature right now. Obviously, everything is on hold until we get through COVID-19, but one of those are going to go through. And as I do return to play, I'm going to have to get through that particular state law. In addition, each district has a law, has a policy. So you're going to have to know, as you clear kids, what's your state law, what's appropriate for them medically, and have you met the requirements of that particular district? And that's extremely important, because the last thing you want to do is have an athlete ready to go back. You've got them psyched to go back. They cleared everything. And then you go ahead and find out that you've missed something as the clinician. And now you stress this kid out because you have not done your job and basically managed to miss one of the three criteria to go back: your state law, your medical criteria, and your school district or individual school criteria to return to activity. So in a lecture that basically takes me 2 hours to do, I'm hoping that in a quick 40 minutes, we've kind of gotten you up to date on everything that we're looking at in concussion in 2020, with the understanding that, unfortunately, even if you're really comfortable tonight, probably come the late fall into spring, this is all going to change again. But the good news is, hopefully once COVID-19 is over, in a year or 18 months, we can come back and go through this again and kind of bring you all up to speed. So I thank you for your attention tonight. I know a lot of you have got a lot going on in life, and social distancing has really been stressful on everybody. So I appreciate your coming and hopefully getting your mind off it for 45 minutes.
Thank you, Dr. Franks. This was an extremely informative presentation. For our attendees, if you have any questions, please utilize our Q&A button at the bottom of the screen. But we do have some questions that were sent in advance.
Excellent.
Yes, one question that we have is, how long is a normal course for symptoms to present for concussion? And at what point after an injury should someone seek additional examination if they're still experiencing concussion symptoms?
Well, I'm going to take the second part of that first. So I always say to people, if you suspect a concussion, you need to see a medical provider and let us make the decision. Because if you end up not being right, and we have a case of second impact syndrome, and even here in New Jersey, we are extremely aggressive when it comes to concussion management. We had a case of second impact syndrome less than 6 years ago, and it was devastating. It was actually resulted in a fatality. So if you suspect there's concussion symptoms, get them to somebody who does a lot of this or is confident in their ability to do this, and let us decide if it's a concussion or not. Most concussions, as far as symptoms are concerned, are better in 7 to 10 days. And we're considering persistent post-concussive symptoms, any symptoms that last greater than 2 weeks in an adult and greater than 4 weeks in an adolescent or child. And when we use those terms, we are using those terms with the understanding that probably something else that's been triggered with this kid is what's leading the symptoms to go longer. I.e., I have a lot of kids who come into clinic, they test well, I put them on the computer and their computer skills are great, but they have a slew of symptoms, and it's mainly because they're so anxious for missing school. So that anxiety is what's driving the symptoms. So you think about, what are the symptoms of anxiety? Headache, can't concentrate, don't do well in school. What are the symptoms of concussion? Headache, can't concentrate, don't do well in school. So me as the clinician have to decide, am I treating anxiety, or am I still treating a concussion? And if you do a lot of this, and one of the things that's going to come out in some of this new data is you're really treating anxiety now, the concussion's over. So it's going to be a really big shift to understand that you had a concussion, but the concussion's better. Now you have anxiety, and that goes with depression, that goes with migraine, so you kind of have to really be, up on your understanding of how other things in medicine can drive the concussion, not the concussion itself.
Wonderful, thank you. And I think we have time probably for just about one more question, which is, could you speak to your thoughts on the ways to prevent concussion and injury and re-injury? What are your thoughts on things that can be done?
So the data on prevention is a lot more dicey than what we talked about tonight. So some of the things that have some decent literature behind it in terms of prevention is, the best data is rule changes. that we've gone ahead and we have either endorsed and followed the rules that are appropriate for that sport, i.e., no checking below a certain age, i.e., heads up football tackling. The data behind that is fairly decent. More anecdotal with prevention is something like neck exercises to increase strength when it comes to preparedness for that particular season. Better helmet technology, although there's no helmet, that basically can prevent concussion. The designs are mitigating force a little bit better. So the literature is not as good at right now, but the question is, as technology gets better, can we see a little bit more prevention from some of the hardware and equipment that we're using? If you watch a lot of documentaries on concussion, news programs on concussion, there's sensors and everything that are measuring the G forces, mouthpieces, shin guards, helmets. But the problem is, it may be registering the hit and how bad the hit is. But if you think about the brain, I tell people, a brain is like a tulip. So, and if you think about a tulip with kind of a case around it, when you hit that body or you hit that head, you may have the biggest helmet on in the world, but the tulip is still moving within that helmet. And that's the problem. The brain sits within the skull in water. And even if you cushion the skull as much as you can, when that force goes through you, it's still going to move that brain back and forth. And what happens is the brain strikes the back of the skull, then the front of the skull, and keeps doing that until it stops. Until we figure out hardware to kind of address that piece of it, if there is the technology that we have right now, because I think we're going to need to be moved beyond what we're currently looking at. Until we're able to mitigate that, it's going to be really hard with some of our equipment or preventative equipment to really mitigate this.
Wonderful. Well, thank you so much, Dr. Franks. And thank you to everybody who joined us this evening. I hope that you will join us for our other upcoming webinars and events. We have 3 coming up next week. Acing the Virtual Interview with Ainsley Maloney from our Office of Career Services on Tuesday, April 21st. On Wednesday, we will kick off our Workout Wednesday series, which will feature alumni every Wednesday through May 13th, leading 30-minute workouts you can do from home. And then on Thursday, Sarah Endress from our Landscape Architecture program will lead you through imagining and reimagining your outdoor spaces. We also ask that you consider supporting Jefferson's COVID-19 Better Together Fund by visiting jefferson.edu/COVID funding. This special fund, which is already being provided to our faculty, staff, students, and employees, has been established to provide support to the Jefferson community, to those impacted by the COVID-19 pandemic. We thank you in advance for your support there. And be sure to visit us on Facebook and download custom backgrounds to use on Zoom. And thank you again for participating in tonight's talk. I hope you stay safe and well.
Thank you very much. Please stay safe.